Dr. Jillian Teta is a naturopathic physician by training, but really I think what's most unique about her is she's a true naturalist, true lover of nature, and has spent a lot of time really observing nature and observing the world around her. That led her to study biology and environmental biology in college, and then go on to attend naturopathic school. And then it's no surprise to see her career move into a place of ecology itself, focusing on digestive health. So she's written the book Natural Solutions for Digestive Health. She's been in practice for 10 years, focused on digestive health, and also does a lot of programs where she really helps people understand their microbiome and their gut health, and has seen thousands and thousands of tests, and really one of the biggest experts in the field. We're really lucky to have her here today. So thanks, Dr. Jillian, for joining us.
Oh. Dr. Jacqueline, thank you so much for having me. I love that. I love that so much. So, hey, everybody, thank you guys so much for being here. And again, Jacqueline, thank you so much for that wonderful introduction. And I also want to thank everybody like at Emerson for putting this seminar together. Like, it's so much work on the back end. Thank you guys so much. And thank you for hosting. So what I wanted to talk about today is an area where naturopaths and functional medicine doctors have an enormous potential to really help people reduce their suffering, get them results, like reduce their healthcare costs and all of things like that. And that is digestive health. So today we're going to be talking about the ways that we can work up digestive health. And for me, I like to know the reason why. Like, why do we do things? Like, what are we actually going to do today? So today in our chat, we are going to be talking about breath, stool, and a little bit of blood testing. So what types of problems they can uncover, the exact things that we can glean from them, including their limitations, right? And the reason why we do this is that digestive complaints are so common, not just globally, but also in the United States population. IBS alone, for example, can be found in up to a quarter of the entire population, which includes children at any given time. Small intestine bacterial overgrowth is about 75% of IBS cases. And we're not even talking about things like indigestion or reflux or all of these other types of things. So these exquisitely common digestive distresses are an enormous reason why people are going to seek out folks like us, conventional doctors. It's why they're going to miss work. And it's why our economy is going to lose a little bit of money. The other reason why we want to have a decent grasp of digestive testing is that, as you guys know, a lot of digestive symptoms, like if you think about reasons for bloating, this can be caused by literally dozens of different things. So many of the reasons for the very common digestive complaints are all overlapping, right? They all share symptoms. They can also look the same. And so by using testing, we can actually help tease out the different reasons for why a symptom may be presenting. And then once we know that, we can actually give a direction for true and lasting relief, right? So on the financial end, if we think about this, over-the-counter digestive aids, almost $9 billion a year. This is a lot of suffering that we can prevent with just our good, naturopathic functional medicine principles, which is a little bit of subjective intake and testing. So another reason why we are so uniquely positioned to do functional digestive testing is because in general, and there are of course exceptions to this, there is a lack of this widespread, consistent knowledge of the microbiome, right? And how to deal with that. Like if you go to your normal doctor and ask them about your microbiome, they may not have a lot of information. If you bring somebody a stool test, if you bring your doctor a stool test, they're probably gonna be like, I don't even know what this is. And so we are uniquely positioned to bring our expertise in these areas to a broader community. And this is important because an imbalance in the microbiome, an imbalance in digestive health underpins not only like so many digestive health complaints, like including inflammatory bowel diseases, which include Crohn's, ulcerative colitis, microscopic colitis, also celiac disease, also irritable bowel syndrome, but they also underpin non-digestive related diagnoses, including type 2 diabetes, neurodegenerative conditions like Parkinson's disease, depression, hypertension, obesity, and more. So there's a huge avenue there that we can explore. When we have this objective data, right, like what's actually going on in the microbiome or in the small intestine or what have you, and we combine that with excellent history taking and asking the right questions, you are able to save your clients so much time and money and pain and suffering just by doing these tests and just by taking a good intake and a good history. So I want to kind of lay out some of those parameters that I have found from doing these tests over and over again. And for context, I do hundreds of stool tests per year between not just my clinical practice, but also a stool analysis service that I offer several times a year called Dysbiosis Detector. I do a ton of stool analysis and a ton of breath analysis. This is pretty much like what I do for practice. And so I have a lot of experience, and I hope to share some of the patterns that I see with you guys so that you can get your clients feeling better, faster, with less money, and all of those things. So the last thing I'll say before we actually jump into the goodness is that this pandemic, like COVID, I don't know about you guys, but I have seen an enormous uptick in different types of digestive distress, specifically like indigestion, diarrhea, heartburn. The pandemic is chronically grinding us down, and it's exacerbating or introducing digestive distress. And so we are uniquely positioned to alleviate that distress for a broad swath of people. And I'm hoping that today I can help you guys sort that out a little bit. So let's see. So first, we're going to talk about breath testing. And so here's how I think about breath testing. First, what does it assess? It assesses small intestine bacterial overgrowth. It can assess fructose malabsorption. It can also assess H. pylori infection. If we break it down a little bit further, for small intestine bacterial overgrowth, we will see that there is either hydrogen dominant, methane dominant, or hydrogen sulfate dominant. We also can have a grouping of these things, right? So it doesn't have to be just one, it also can be several of those things. Now, when are some situations in which that we actually would recommend a breath test? So how I think about this clinically is if there are a lot of upper gastrointestinal symptoms, particularly around meals, that especially include a lot of gas symptoms, like bloating or distension or belching, like upper gas, but also early satiety or even heartburn type symptoms like reflux, like the sensations of heat or burning that are not relieved by heartburn treatment, right? And that includes things like gnawing pain in the stomach. These are things that should clue you in that maybe there is an upper GI problem. If, in addition, there's motility issues, like if there's diarrhea or if there is constipation, like things are slowing down and they are correlated with these upper GI issues. If the gas or the stool smells like a drain or like sulfur, those are all indications for a breath test. Those are great indications for a breath test. If there is a medication that increases the risk of small intestine bacterial overgrowth, which includes depression medications, anxiety medications, proton pump inhibitors, and antibiotics, that is definitely something that should get your clinical brain thinking in conjunction with all of these like symptoms that perhaps a breath test is indicated. Also, something to think about just in terms of history is that there could be a diagnosis that's often found concurrently with SIBO. The biggest one here is irritable bowel syndrome, but IBS, right? But there's also other things. So any other digestive diagnoses actually increases the risk for SIBO. And then there's also things like traumatic brain injury and history of recent surgery where you have gone under generalized anesthesia. Anything that has recently suppressed the central nervous system can also increase your risk for SIBO. What do these tests actually do? So they measure gases in the upper GI tract that shouldn't be there. And how they're administered is they're either done in office or in the privacy of our client's home. A baseline breath is taken, like they're, we blow in these like little tubes that look like little breathalyzer tubes. So we take this baseline in the tube, then we drink a solution, then we administer the test, which usually lasts like 2 to 3 hours with serial measurements taken thereafter. These tests can be done at home or in the clinic. And it's sort of it's like a clinical judgment for you, whether you want folks to come into the office or if you want them to do it at home. You just sort of need to like chat with your client and sort out like what works best for them. Now, a big question in the community is what medium do we use for a breath test, right? Like what is that actual solution that we drink? This, of course, is water. But there are a couple considerations for mediums with breath tests. And I want to like kind of just cruise through some of those real quick. The first is if you're testing for fructose malabsorption, which, by the way, is rarely a first thing out of the gate, like we need to test for fructose malabsorption right now. Like it's not a common thing that we first test for. But that medium is going to be fructose, right? So we're going to see if fructose is metabolized or not in the upper GI tract. If someone is testing for H. pylori, like if you're going to your doctor and you're having an H. pylori test, they're going to give you urea. Now, there are alternatives for testing H. pylori, like including the PCR testing. We're going to talk about that in a little bit. But it's extremely important to get the right medium for the right test. So for SIBO, we have options. So for small intestine bacterial overgrowth, there are 2 choices. We can use a lactulose medium or we can use a glucose medium. In my career, and again, I have been in practice since 2007. I have primarily focused on digestive health, mostly because that is just who has showed up to my practice. And every year, I do hundreds of stool tests and I do hundreds of breath tests. And I am constantly reading the literature for both. And so this question of lactulose versus glucose is just like fascinating to me. So here's a couple things to consider for when we think about taking lactulose versus glucose as a medium for small intestine bacterial overgrowth testing. So glucose is absorbed proximally, right? It is absorbed quickly and fast, right? So that means that it's mostly absorbed in the first part of the small intestine. that means inherently it can miss, because it's gone, SIBO that's present in later segments of the small intestine, the jejunum and the ileum. Lactulose, on the other hand, is absorbed distally, meaning that it can travel the entire length of the small intestine without being absorbed. And so if there are bacteria present, they are going to be fermenting through all of the segments, right? So it's going to capture SIBO in all segments. There are going to be fewer false negatives with a lactulose breath test, but it is great to know that both lactulose and glucose are about 85% sensitive and specific. For any test, those are pretty good numbers. Now, I wanted to include this slide on results for breath tests because a lot of my clients and a lot of the clinicians that I speak to seem to have confusion about this. So just real quick, with the North American Consensus Group, this right here is the standard for how we would diagnose SIBO, which is if you have a peak in hydrogen that is greater than 20 parts per million, greater than baseline, you've got SIBO. If you have a rise in methane that's greater than 10 from baseline, that's positive for methane SIBO. You do not need both hydrogen and methane to be diagnosed for SIBO. And an interesting factor is that if you are high in methane, a lot of the methanogens actually consume hydrogen. So a very high methane breath test can often cloak hydrogen SIBO as well. So that's just something to consider in terms of antimicrobial care, because we see this quite a bit. Another thing to consider with SIBO, because it's only, 85% is great, but also it's only 85%. So what does that mean? That means that 15% of cases can be missed. So false negatives are far more common than false positives. So we're more likely to actually miss a case of SIBO than to actually incorrectly diagnose it or to diagnose a false positive. And then I did write something here about equivocal results, because if you're in this long enough, you are going to get plenty of tests that are methane of 9 and hydrogen of 19 or hydrogen of 20. So these are very equivocal tests, right? Not quite positive, not quite negative, based on your subjective experience with this client, based on your history and your intake and other symptoms and your physical exam. Then you get to decide, do you treat for SIBO or do you not treat? And that is a individual and unique clinical consideration that's kind of outside of the scope of a presentation like this, but that I would certainly be willing to chat with people on Instagram or something like that if you guys have questions about how to move forward with that. That sort of gray area also can be extremely interesting, especially when someone is highly symptomatic. And so a very common question that we get here is, okay, if we are talking about functional digestive testing, should we start with a breath test or should we start with a stool test? And although it's not inherently intellectually satisfying, my answer to this is always, it depends, right? So sometimes it's going to be one thing and sometimes it's going to be another. So first things first, we have to connect with our client, connect with our patient. We have to get a very thorough timeline of their subjective and objective experience with their digestive symptoms, which includes even going way back to childhood and infancy. So we want their timeline, we want their history, and we want how things feel to them? Are they experiencing it in their upper GI? Are they experiencing it in their lower GI? Like, how do they feel? Like, what makes it feel better? What makes it feel worse? Like, what happened to you when you were a child and you were, having stomach pain in the 2nd grade and like had to run to the bathroom and all of these types of things. History is unbelievably important in digestive distress because these symptoms that create digestive distress, again, can be caused literally by dozens of different things. So history taking, chatting with your clients is exquisitely, extremely important. We also have to take into consideration that will help us sort of point us in a direction. Have there been other diagnoses? Like, do they have IBS? Do they have IBD? Have they been diagnosed with acid reflux? What testing have they had? Have they had endoscopy? Is there evidence of erosion of the esophagus? Like, how does their large bowel look? Like, is there inflammation there? Like, what types of treatments have happened over the years? We need to really get a great picture. And that picture will help us decide, do we want to do a breath test, which truly does evaluate more upper GI symptoms more so than lower? Or, and really breath tests are they're really like ferreting out small intestine bacterial overgrowth. Or could it be something that is maybe responsible, maybe the responsibility is coming from the lower bowel, right? So like, are symptoms mostly below the belly button? Do they get worse as the day goes on? Like, is there lots of lower gas, lots of lower bowel discomfort? In these cases, we probably might want to approach a stool test over a breath test. Other questions to consider, that are just important, just for your history taking. When did symptoms start? So if symptoms have started after there's been travel, or after an illness, or after food poisoning, we may want to err on the side of doing stool testing versus breath testing. Because stool testing gives us a very the word comprehensive, we're using this term so much in this presentation, but stool testing gives a very complete picture into the GI tract. So not only the microbiome and bacterial balance, but also the digestive capacity in terms of acid, enzyme, bile output. And then we also have immune markers like SIGA and anti-gliadin SIGA, and then inflammatory markers like calprotectin. The only limitation of the stool testing is that it really can't pinpoint upper bowel stuff. It cannot pinpoint, it cannot diagnose SIBO. So sort of the overarching thought here is, if you want to do a big picture analysis, if someone's maybe new to you and you're not exactly sure where to go, you probably want to do stool testing. If you're confident it's an upper GI problem, if things are looking very much like SIBO or indigestion or H. pylori, or if they've already had stool testing, then it's probably time to do some breath testing and to rule in or rule out small intestine bacterial overgrowth. So those were some sort of distinguishing factors, things that I would consider whether I'm thinking of testing someone for SIBO or if I'm testing someone for their microbiome, their actual microbiome, and how that is impacting their symptoms and their overall well-being of not just their gut, but their entire body. So for stool testing, the things that we're looking at here, and the reason why I adore stool testing and use this as a tool frequently in my practice, is that it examines so many aspects of the microbiome and of gut health. pretty much the only thing it can't do is pinpoint SIBO because it's a stool test, right? So we can't tell from the stool if this is coming from the upper GI or for the lower GI. So that is extremely important to like get in our brains and differentiate, because it's not apples to apples. It's apples to oranges, and the two things do different things. So our stool testing qualifies and quantifies the microbiome. Who's there, how many, like the good, the bad, the in-between, and the ugly. It also will identify parasites and pathogens. And then it also does these lovely things that gives us a kind of more comprehensive look into digestive health, which is looking at digestive capacity, right? Our output of enzymes, bile, and in some cases acid, our immune capability, our state of inflammation via calprotectin, and then some of them do antibiotic resistance. If they find a bad guy, they will also do a culture and sensitivity test to see what will kill the bad guy. So these tests can elucidate an enormous amount of information that can give your clients fast relief and save them a ton of money. And a ton of money meaning on like missed work, unnecessary doctor's visits, unnecessary supplements, unnecessary over-the-counter stuff. Like the potential is just super exciting. And anyway, that's why I do what I do. So anyway, so one of the questions, like with breath testing, there are a number of stool tests that we can choose from. And the fundamental question is, do we do more PCR-based testing, which is a genetic amplification? It's a genetic probe, meaning like if the organism is there, the genes are there, or do we do microscopy? So there's advantages and disadvantages to both. And these are some of the things that I have learned, like based on research of like all these journals that I've been reading forever, and then also based on clinical experience, like of just using so many of these tests since 2007, since when I've been practicing. So here's a couple things like clinically that I just want you guys to think of as well. So first of all, microscopy can overreport yeast. And this is because of the preservative medium, okay? So what can happen is we take the stool test and then it's like, we put it in the tubes and then we send it into the lab. Like with that time interval, yeast is capable of overgrowing. Also, anaerobes, any bacteria or any like archaea or any organism that thrives in a no or low oxygen environment is inherently going to start dying immediately when it's put in a test tube or taken a sample of, right? So inherently, microscopy is going to miss these things because they are going to be dead, where PCR would capture them because even if they're dead, their genes are still present in there, all right? Another thing about, another like sort of like weighing these things, PCR testing does not do culture and sensitivity trials, which the microscopy does. And that can be enormously helpful in some cases. Because sometimes there's definitely, especially in certain cases, there can be extreme like antibiotic or microbial resistance to certain compounds. And for some folks, that's important to elucidate. That's not necessarily always important for every single person because we have a lot of fabulous antimicrobials, both conventional and natural, that like work beautifully, but this is a consideration. A consideration on the PCR side is that even if a parasite or a pathogen is not actively shedding in the stool and it's not actively present, PCR can pick it up because the genes are there. And so Dr. Jacqueline told me that like with this presentation, I could tell my preference. And although I have used both testing, like both PCR and microscopy testing in my career, like right now, I am currently using PCR tests far more. And I'm also using lactulose breath tests more. I'm not sure if I actually said that. I'm not sure if I said that. So a couple things about microbiome testing. Here we go. So the first thing is that we just have to acknowledge is that there is still so much about the microbiome that we just don't know. We just don't know. But based on the few things that we do know, we are capable of offering a great service to folks in terms of their digestive distress, because we can give answers and then solutions that mitigate that digestive distress. So it's just an enormous clinical opportunity for us. So here's how these things are broken down. A big part of the stool test is actually looking at like the healthy, beneficial bacteria, microbes that should be there, like who's there and how many of them are there. And so in terms of evaluating this stuff clinically and how it means for our clients with their symptoms, there are definitely a few trends that we should look at in terms of just like the quote, like the beneficial flora. So some things that I see very commonly is that there are simply low flora. Now, what I will say, the most clinically relevant insufficiency in digestive flora is in the phyla, right? So phyla is a very high taxonomic organization. It's way above things like order and class and genus and species. So if a phyla is low, that is an indication that overall there is low beneficial flora on board, and that we probably need to intervene with fiber, fermented stuff, maybe probiotics, like all of this type of thing. The rub with all of this stuff clinically is that low flora can actually mimic signs of overgrowth, whether it's like overgrowth of opportunists or overgrowth / infection of bad guys. And so that is actually a decent reason why it's good to do testing to actually see, because we might be treating someone for overgrowth or infection or yeast or like whatever, and really truly they have low flora. So those are two different avenues, but it's extremely important. Another common trend that I see is overgrown flora, right? So overgrown native flora often happens hand in hand with growth of opportunists, because those opportunists are in different phyla that overall elevate the phyla of the entire microbiome and drive those numbers up. Now, another thing that we see that's just is worth putting like this little clinical pearl in is that something that we can see in the native flora section is that the phyla Firmicutes might be high, or the ratio of Firmicutes and Bacteroidetes is high. And so Firmicutes, or high ratio, is associated with blood sugar dysfunction, a higher caloric extraction from food, like blood sugaring issues, and then all of that like associated fallout. So that's definitely something to be keeping your eyes on, especially if someone is struggling with blood sugar, struggling with sleep, maybe struggling with like keeping weight where they want to, and all of those types of situations. With stool testing with native flora, you of course always want to take an extremely thorough timeline and history on nutrition, including when folks like were children, when they were in high school, when they were in college, if that was applicable, their uses of antibiotics, proton pump inhibitors, and other acid blockers, laxatives, atypical antipsychotics, travel, illness, like where they work, exposure to pets, like do they have a farm, do they have a barn, like wild animals, gardening, camping, drinking from hoses. All of the bacteria that are associated with these things often show up in stool tests. And so having this information ahead of time is going to save you a ton of time with your analysis and just helping folks like get where they need to be. So another major section of the stool testing is opportunistic bacteria. And this is probably one of the most interesting sections in terms of helping folks get clinically significantly just better and more relief. So opportunistic bacteria, right? Like right here, like emphasis is on the opportune. So when there's stress, when there's compromise, when there's like weird travel, when nutrition's not great, like these guys just like they get a toe in the door and they move in. Depending on the person, the symptoms literally can be 0 symptoms or incapacitating, right? So this is where we need to like take that very thorough history and do decent testing, because we just aren't going to know until we're able to put the complete picture together. So based on like what organisms show up, some of those have very distinct symptoms. It's like some have very distinct symptoms, but it's also important to know that a lot of these symptoms overlap between organisms, just like a lot of general like digestive symptoms like gas and bloating overlap with dozens of different diagnoses, right? So we just need to take everything in perspective. And I know that like, you know, for a talk, it's very hard to like cover all of these nuances, but I just want to make that extremely clear that like it does have to be a comprehensive picture. I am going to try to give you guys some of my best highlights, and here we go here like with this slide and some sort of qualifying, like this is definitely like not a comprehensive list, but there are some opportunists that you guys can link with certain clinical pictures. And I have them listed here. So like some opportunists are greatly associated with antacids and proton pump inhibitors and acid blockers. Some are associated with a lot of antibiotic use and or antibiotic resistance. Some are associated with releasing histamine in the gut. Some are associated with small intestine bacterial overgrowth. Some are associated with harming the lining of the gut and or contributing to or exacerbating colitis and inflammatory bowel disease. And I have listed some of these guys out. And truly, like, if you guys want to hit me up on social media, like on Instagram and like chat about cases, I'm actually totally open to that because I find this stuff so fascinating. But there are definitely certain bacteria that we can correlate with certain clinical pictures that both confirm the clinical picture and then also like give direction for sort of like just where to go. These stool tests also test for like candida and fungus. Candida is often overdiagnosed with microscopy. That is something extremely important to know because our general sort of like alternative medicine community is like extremely biased towards yeast. And I feel like there's lots of like kind of bunk ways that yeast is diagnosed that are not actually like clinically proven or relevant. So anyway, based on that's a little sort of tangent there. Some of the yeast that are tested on stool testing can be dietary artifacts, right? Like geotrichum, which is found in lots of like cheeses and wines and things like that. Some yeasts, however, can be dangerous for folks who have real immunocompromise or have had organ transplants or those sorts of things. Something that's really important to know is that the main gas that yeast produce is carbon dioxide. Carbon dioxide diffuses into the blood and is exhaled through the lungs. So yeast and fungus does not cause like gas and bloating like bacteria do. So I think as like naturopaths, at least, we need to like get real about like what yeast does and doesn't do. And so this is definitely one of the things. Like yeast puts off carbon dioxide, it goes into the blood, it's exhaled through the lungs. And the nice thing clinically is that yeast like Candida or other types of like pathological yeast, meaning like their levels are infectious, are present. Yeast is actually one of the easiest microorganisms to treat with probiotics, Aspergillosis, nystatin, alicillin, those are garlic derivatives, all those guys. All right, moving along. Stool testing also covers parasites and pathogens. So parasites, so the difference between these guys is that parasites live within and they feed on the host. Like the host is important for their survival. It's like the expense of the host is their life. Pathogens are not necessarily dependent on the host, and they basically just cause like a lot of like gastric distress. So stool tests will qualify and quantify both protozoal and warm parasites, bacterial, viral, and parasitic pathogens. So again, it's like, it's just extremely comprehensive. If you happen to find a parasite or a pathogen, you want to correlate that with other measures on this test, including secretory IgA, which will help you elucidate whether this is a recent infection or a longer-term infection. Calprotectin, which will help you elucidate if this is a very high number of organisms infecting the body, like H. pylori, like a bad H. pylori infection in and of itself can increase calprotectin. And then we also want to look at native flora, like our native flora low, and that's why we have parasites and pathogens present, or are they robust? And we just had a parasite or pathogen like kind of just come on board anyway. So all of these things, like with these tests, you kind of compare everything against the other. In terms of treatment, most of them are straightforward. However, some parasites and pathogens, antibiotic therapy is contraindicated for them because of hyperuremic syndrome. So you always want to look up these organisms if they happen to show up to like see who's treated by antibiotics, who's not, like when is it better to use just like probiotics and natural antimicrobials and so on and so forth. So, because we're getting a little close to time, these are just some of the parasitic highlights that I have noticed during my clinical years, right? So blastocystis is extremely common. Many sources will say that it's non-pathogenic and that it can be difficult to eradicate. So I do often see this like present, not necessarily high in many cases. And this is one of those things where it just has to be taken in context with everything else. So if someone is highly symptomatic and this is the only thing that shows up on their test, treat this thing, right? So it kind of depends. Some other things that I have seen a lot is cyclospora, which is a protozoa. It's a very common source of traveler's diarrhea, even if it's not high. So I cannot even tell you guys how many times I have done stool testing and cyclospora pops up, not in a high amount, but folks report diarrhea, incontinence, all of the, pain, spasm, all of these things. And we do an antimicrobial intervention to get rid of this and it's gone. So then we have some other worms and such. I'm highlighting these guys just to say it's worth asking folks, do you guys have pets? What kind of pets? Do you garden? Are you in the dirt a lot? Do you drink out of hoses? Do you visit farms? Do you visit wineries? Do you visit dirt? All of those things are extremely important for building that clinical picture. Now, with your pathogens, here are some more that I often see. We have bacterial, parasitic, or viral pathogens. And again, this is not a comprehensive list of the guys that I see. It's just a few things that I want to just bring to the attention. So Campylobacter is an organism that brings lots of pain below the belly button and diarrhea. And I always like to look for this organism in folks that have had an increase in like looser stool, higher motility. They don't know exactly what's going on. Maybe they didn't travel, but something just seems afloat. The dietary and supplemental interventions like are not working. We like to do a stool test to just see like what organisms are on board that could potentially be, you know, contributing to this. And Campylobacter is one. I have enterohemorrhagic E. coli here just as one of the organisms as an example to not use conventional antibiotics for because of the risk of hyperuremic syndrome. And then I have another list of some organisms that you do not want to treat with conventional antibiotics because of hyperuremic syndrome. But you do want to Google each organism that you find just to be on the safe side. All right, loves, let's keep moving on. Okay, yes, all right, so I am an animal person. I have tons of animals. I love animals. I take in stray animals. We have a huge garden. And so as a result, I just need to tell you guys about entamoeba, which is a parasite that you can get from pets, from farms, from petting zoos, and then also, unfortunately, from like small children, from daycare, from, you know, school care centers, and from sexual partners. It is a highly transmissible parasite from close contact. This is something that can be treated conventionally, though. And then we have on the protozoal side, Giardia, which of course I'm sure all of you loves are familiar with. It's extremely common from camping, right? Like lots of people know, like, oh, you know, don't drink out of the stream, like have a water purification system on board. Giardia is a major reason for this. And luckily it too can be treated with conventional and natural antimicrobials. So another thing that I like about stool testing is that it will look at H. pylori on the PCR side, right? Like from the genetic perspective, right? So not just the breath test. And over 50% of the entire globe has H. pylori. And like many other organisms, like the implication of its presence can have symptoms that range from 0 to severe. So it can do nothing to you. It can give ulcers to you. It can give gastritis to you. It can increase your risk for certain gastric cancers. But yet in other populations, it's protective against cancers or these same sorts of things. So if we look at PCR testing, PCR will see if the actual genes for H. pylori are present. So we get a better picture than just breath test. And then with PCR testing, we also get an additional look into the virulence factors that would confer greater risk of ulcer, gastritis, or making H. pylori more difficult to treat. And so with H. pylori, you take those findings and you integrate them with the symptoms, right? Like, are the symptoms high or low? Are there other symptoms of overgrowth? Like, what is calprotectin doing? Like, what is SIGA doing? You sort of integrate that with everything else to see, like, is H. pylori, like, is this something worth clinically treating or is it not? And then we have some markers for intestinal health with stool testing, which are also enormously clinically relevant because what they're looking at is our digestive capacity. So the ability to break down proteins, fats, carbohydrates. Is there blood present in the stool? Is there antibody present in the stool, whether it's just SIGA or whether it's associated with gliadin? Is there calprotectin? Is there zonulin? And then are there antibiotic resistant genes? So there's just so much information that we can glean here. And why do we want to know? Like, why do we want to care about digestive capacity? Also because lower digestive function also overlaps symptom-wise with overgrowth of opportunists, infection of pathogens, and low gut flora. So we want to know, like, are these folks actually producing enzymes? Like, do they have good bile flow? Like, are they producing acid? Like, what's going on? Like, and if they're not, like, if these symptoms go long enough, not only are they just GI symptoms, but then we're getting into like motility issues and like nutritional insufficiencies and deficiencies and such. So we really want to like parse all of this out and just get a really good idea of what's going on with what. So in terms of the PCR tests that I use, they use elastase 1 and they use steatocrit. In other tests, they look at protein fibers, right, which is a marker of acid production. So let's kind of look at this a little more in depth. Elastase 1 is a pancreatic enzyme that is independent. So this is released by the pancreas, but it's independent of supplementation. So this is a great evaluator of whether someone has great or good or not pancreatic output of digestive enzymes. In terms of fat and bile digestion, steatocrit is a measure that is used to see if bile flow and bile production and actual like digestion of fats is in point and on board, right? So if steatocrit is high, that's an issue that we need to address in terms of shoring up fat digestion. If elastase 1 is low, that's something that we have to shore up in terms of enzymatic supplementation with meals. And I know we are getting close to the end of the time. So, oh, there she is. Hey, sweetie. Ooh, she's just there. So I'm just going to keep going. So we're going to keep looking at the immune and inflammatory markers. So if SIGA is high, we want to think about frank or recent infection. If SIGA is low, you're thinking about long-term infection, environmental exposure, or like protein insufficiency. With anti-gliadin SIGA, like with this, we are looking at reactions to gluten in the lining of the gut that is independent of blood reactions that are actually in the body. And if that is high, you do actually want to do a elimination of gluten. Now, calprotectin is an actual inflammatory marker that is released from neutrophils, and it is the gold standard of like inflammatory bowel disease, both the how well like treatment is working and how severe disease is. But I don't want to leave it at that, because high calprotectin can also be caused by NSAID use, H. pylori, diverticulitis, like cancer, and all of those things. So if calprotectin shows up on a stool test, like we definitely want to follow up with that. Zonulin is also on these stool tests, and that is it's a compound that will open the tight junctions of the lining of the small intestine. So this is like a loose marker for intestinal permeability, AKA like leaky gut, which is a underpinning factor of inflammatory bowel disease, celiac disease, microscopic colitis, like all of these sorts of things. And then lastly, with the stool test, we have antibiotic resistance, where they will look at antibiotic resistance of the microbiome and also for H. pylori. And they look at a number of different antibiotic classes, which I have listed out here, which is extremely helpful if you are looking for conventional treatment. And then this last little thing here that I have for you guys is just blood testing. And I spent less time on this because blood testing isn't like I don't really consider blood testing like a functional aspect of stool testing, but we also can get like great information about digestive health simply with blood tests, especially for gallbladder and liver function health testing. So we have our like liver evaluation for fatty liver and for liver enzymes. We also have, there are now blood tests for celiac disease, for for irritable bowel syndrome, for systemic inflammation that is often found with inflammatory bowel syndrome, and that you can correlate with your calprotectin. And then also we can use blood tests to like assess for anemia and nutrient deficiencies that are caused by all of like the digestive distress and conflagrations that we have like discussed thusly. So those are our blood tests. And with that, my dears, I will thank you for listening and open it up to questions. And also tell you that if you guys like Instagram, please find me on Instagram at Jillian Teta. I talk a lot about digestive health. I have like my gardening and like kind of all the behind the scenes stuff here at the house, but then I also have like all my weird like social justice stuff. So like, come on over if you guys want. Come on over, you guys want.
Great.
And thank you so much. Like, thank you so much.
Thank you. We don't have any time for questions today, but we are really grateful. This is obviously such a huge topic and one that you have a lot of passion about. So I would encourage you, if you had a question that you submitted, I'm so sorry we can't get to them, but connect with Dr. Jillian on Instagram, and she does share tons of great info there. So thank you so much.
Thank you, guys.